lecture today is the biliary system. Biliary system consists of gallbladder and bile ducts. First, we will talk about the gallbladder. Gallbladder anatomy, it's pear-shaped sac attached to the extrahepatic bile ducts by cystic duct. It's about 10 centimeter length and 3 centimeter width. Its wall thickness up to 3 millimeter. It's composed of 3 parts, the fundus and body and the neck, as we see here in this image. It hangs in the visceral surface of the liver with its neck lying superiorly and its fundus inferiorly. A pouch called Hartmann pouch on its ventral surface proximal to the neck is seen when gallbladder is dilated in disease, probably not normal anatomical feature. Here we see it near the neck. It has a clinical significance when a stone is impacted here or in the cystic duct, causing compression to the common hepatic duct and leading to Merisi syndrome. Gallbladder covered by peritoneum on its fundus and inferior surface. A mucosa lining the gallbladder is smooth except the neck, and the neck and cystic duct forms folds that arrange spirally called valve of Hester, which is very echogenic on ultrasound, sometimes confused with a stone. Here the spiral valve of Hester. Anatomical relation, anterosuperiorly gallbladder bed of the liver and the fundus related to the anterior abdominal wall. Posterior inferiorly, the neck is related to the lesser omentum and hepatoduodenal ligament, and the body related to the first part of duodenum, and the fundus related to transverse column. Normal variants of gallbladder, the lumen may have septum, which is either single or multiple. The fundus may have folded back on itself, leading to pharyngeal cap. Diverticula also may be occur anywhere at the gallbladder. Commonest site is the fundus. The clinical significance of these conditions, they have biostasis and formation of stone. Gallbladder also have variant location, maybe either retrohepatic, suprahepatic, and intrahepatic, which is normal in fetal life up to 2 months. Left-sided gallbladder may be seen also if under the left lobe or herniate through the epiploic foramen or as part of the transposition of the viscera. Rarely absent of gallbladder and doubling of gallbladder. Here, the picture of pharyngeal cap, as we see here, sonographic image and gross image. Multiple septated gallbladder in sonography, giving rise to honeycomb appearance sometimes. Diverticula of gallbladder as seen in sonographic and contrast image near the fundus, most common site. Suprahepatic and retrohepatic gallbladder, suprahepatic seen just posterior to the anterior abdominal wall, and retrohepatic gallbladder seen posteriorly between the liver and the kidney. Intrahepatic gallbladder seen as cystic structure in the intrahepatic parenchyma, confused sometimes with a cystic lesion. This is normal in fetal life, seen as intrahepatic structure up to 2 months. Left-sided gallbladder, as seen in this CT axial image in situs inversus, seen the left side the liver and gallbladder and spleen on the right side. Also, as we said, if seen under the left lobe or herniate through epiploic foramen. Duplication of gallbladder, either partial or complete. The most common appear at sharing one duct. This is the sonographic image. Arterial supply of gallbladder. Gallbladder is supplied by cystic artery, branch from right hepatic artery, and also supplied by directly from the liver in the gallbladder bed. This is the cystic artery. Venous drainage of the gallbladder is drained via small veins to the liver directly in the gallbladder bed. Sometimes a cystic vein formed at the drain to the right portal vein. The lymphatic drainage of the gallbladder, it has 3 pathways. The primary pathway, which is the cholecysto-retropancreatic pathway, to the retroportal nodes posterior to the pancreatic head, and also have the cystic cholecystoceliac and cholecystomesenteric pathway. As we see here, this is the celiac lymph nodes and superior mesenteric lymph nodes and cystic nodes. The bile ducts. Intrahepatic bile ducts follow the same pattern of distribution as the hepatic arteries. Bile ducts from segments unite to form right and left hepatic ducts. This is the left hepatic duct, and this is the right hepatic duct. Right hepatic duct, it's composed of two ducts, the right anterior duct that drain segment 5 and 8, the anterior segments of the right lobe, right posterior duct that drains the posterior segments 6 and 7, and the left hepatic duct drains the left lobe, segment 2 and 3 and 4, and the right anterior duct has more horizontal course and usually pass anterior to right posterior duct, which is more vertically, then fused on its medial side to form right hepatic artery, hepatic duct. Bile duct draining the caudate lobe, joining either right hepatic duct or left hepatic duct. Right and left hepatic duct have diameter up to 3 millimeter. As we see here in this diagram also, this is the right anterior, sometimes called the medial, and this is the right posterior duct, and this is the left hepatic duct, joined together to form the common hepatic duct. Common hepatic duct formed by the union of right hepatic duct and left hepatic duct outside the liver at porta hepatis. It lies anterior to portal veins in a free edge of lesser omentum, the hepatic artery on its left side, the mean diameter about 7 millimeter. It joined the cystic duct after a variable distance, usually 3.5 centimeter. Cystic duct connect the gallbladder to common hepatic duct to drain the bile. The confluence with the common hepatic duct form the common bile duct. It's about 3.5 centimeter length and 2 to 3 millimeter in diameter and lies anterior to the cystic artery. Here in MRCP study, this is the cystic duct. Common bile duct formed by the confluence of cystic duct and common hepatic duct. It's about 8 centimeter length, less than 6 millimeter in diameter. The diameter can increase with the increasing age. The upper limit is 1/10 of the age of the subject in millimeter. Also increased after cholecystectomy, reaching up to 10 millimeter. The common bile duct has 3 parts. The supraduodenal part lies in the free edge of lesser omentum, hepatic artery on its left side, and portal vein posteriorly. Retroduodenal third, behind the first part of duodenum, runs with the gastroduodenal artery. The pancreatic third behind the pancreas and tunnel toward the second part of duodenum. Common bile duct unites with the pancreatic duct at common dilated terminal ampulla of Vater and empties into second part of duodenum via major duodenal papillae. Ampulla is surrounded by circular layer of involuntary muscle known as sphincter of Oddi, which has also variable, sometimes variable location, sometimes reaching the stomach area or seen distally in the third part of duodenum. Variation of biliary ducts. It occurs more in the intrahepatic ducts and occurs over 40% of cases. This is the usual pattern here of confluence of the intrahepatic ducts. The variant, about 20% have the right posterior duct joining the left hepatic duct instead of joining the right anterior duct, and 10% having triple confluence of the right anterior, right posterior, then the left, and the least variant, the right posterior joining the right anterior on its left side instead of being passing posterior to it. Accessory hepatic ducts arise mainly in the right lobe and the liver, either joining the common hepatic duct or joining the cystic duct or joining the common bile ducts, or sometimes having 2 accessory ducts, or the least variant joining the gallbladder. Double hepatic ducts, when right hepatic duct and left hepatic duct fail to unite, giving this appearance. Variation of cystic ducts. Cystic duct has 3 common variations. A low insertion where it fused distally to the CPD, here as low union. A medial insertion where it passed posterior to common hepatic duct to drain on its left side, either passed posterior or passed anterior to the left side of common hepatic ducts. And the parallel course with where it's adhered closely to common hepatic duct for at least 2 centimeters. Now coming to the radiological imaging of a biliary system. Key forms of the abdomen: ultrasound examination, contrast examination, MR cholangiography, CT of the biliary tree, or last thing is scintigraphy of biliary system. Key form of the abdomen: Normal gallbladder or biliary system are not visible on X-ray. Only gas and calcification may appear. Gas in the extrahepatic ducts are considered normal in the following situation, not pathological condition. In the elderly where the ampullary tone is low after sphincterectomy or after surgical anastomosis, choledojejunostomy. Here this pneumobilia, and here the calcification as the calcified gallbladder calculus or calcified wall of gallbladder, the porcelain gallbladder. And here, as in this X-ray image, the gas surrounding the gallbladder in case of emphysematous cholecystitis. And also, we should differentiate between the portal venous gas and the biliary system gas. The CPD, C for central gas pattern, as we see here, and portal, P for peripheral gas pattern. This happened because that the flow of bile pushes the gas toward the hilum in biliary, and the flow of portal veins pushes the gas away from the hilum. By ultrasound, the size of gallbladder varies between the fed and the fasting state. It's about 10 centimeter long and 3 centimeter wide. Wall thickness varies also with the degree of distension. The normal wall is about a thin echogenic line up to 3 millimeter. As we see here in this sonographic image, here's the portal vein and the hepatic artery and CPD, which is called the Mickey Mouse face. And this is the femoral of a gallbladder. By sonography, the intrahepatic bile ducts are tiny structures run with the portal veins radicals. They can often be detected on high resolution scanning and normally measure less than 3 millimeter or less than 40% of the caliber of the adjacent portal venous branches. As we see here, this the intrahepatic bile ducts, the segmental bile ducts, and the right anterior, right posterior bile duct. The upper limit diameter of common hepatic ducts varies with age. The mean diameter is 3 millimeter at the age of 20, up to 8 millimeter in considered normal adult subject, up to 10 millimeter normal in post-cholecystectomy. And the upper limit of CPD is 1/10 of the age of the subject in millimeter, for example, 4 millimeter for age of 40 years. This is normal CPD in sonographic image, and this is dilated CPD with a stone inside it in sonographic also. Contrast examination. Intravenous cholangiography, oral cholecystography, intraoperative cholangiography, T-tube cholangiography, percutaneous transhepatic cholangiography, PTC, and endoscopic retrograde cholangiopancreatography, ERCP. The first two, intravenous cholangiography and oral cholecystography, these X-ray images using the IV contrast or oral contrast, highly replaced now by ultrasound imaging. The intraoperative cholangiography is performed during cholecystectomy or bile duct surgery to avoid the need of surgical exploration to CPD. MRCP and endoscopic ultrasound is replacing this technique. As we see here, this done by the surgeon by cannulating the cystic duct and giving the contrast. And here we have multiple stones seen in the cystic ducts. PTC, radiographic technique that employed in the visualization of biliary tree prior to the therapeutic intervention, for example, for biliary drainage to relieve obstructive jaundice, in the placing of a stent, a biliary stent, and removal of the stone, dilating structure, and rarely used in diagnostic purposes only. Most commonly punctured ducts are the ducts of segment 5 and 6 on the right lobe, and ducts of segment 3 on the left lobe. This is the most accessible ducts, the inferior segments ducts. This is the CHIPA needle used in this procedure. It's fine, flexible needle, similar to the spinal needle, but longer. It has about 15 to 20 centimeter length. Post-operative T-tube, this technique used to exclude biliary tract calculi and the assessment of biliary leak following biliary surgery. The tube is put in position during surgical procedure to transport bile to the small bowel. The examination is performed on or about the 10th day post-operative day prior to the removal of the tube. As we see here, this is the long segment of the T-tube, and this is the short segment with contrast injected, reaching the duodenum. ERCP, diagnostic ERCP has been largely replaced by CT and MRCP. over 90% of ERCP procedures are performed with therapeutic interventional purposes, rarely used for diagnostic, except in cases where MRCP is unsuitable for the patient. As we see here, this is the endoscopic tube, and the catheter introduced to the biliary sphincter, to the common bile duct, and the contrast injected to see the delineating the biliary system. MRCP, excellent images of biliary system with MRCP. We got it and replaced ARCP as first line of investigation. Heavily weighted fat suppressed sequence produce image where the static fluid in bile duct is hyper intense and background signal is suppressed. As we see here, this is the hyper intense bile appeared in delineating also the biliary system and the background signal suppressed. CT of the biliary tree. Biliary system is being best seen on contrast enhanced CT images as low density linear structures run anterior to portal venous system. As we see here in axial CT scan, this gallbladder seen as hypointense structure. CT cholangiography, it's excellent technique for showing the normal anatomy of intrahepatic ducts. It is used sometimes when MRCP failed to display the normal anatomy of the intrahepatic biliary ducts. Contrast with is meclomine iotrexate, bilirubin R, and the CT should be obtained at least 35 minutes after infusion of the contrast. As we see here, the fine details of the intrabiliary ducts. Scintigraphy of the biliary system using technetium M99 high-def scan. This radioisotope tracer accumulates in the liver parenchyma and then excreted by biliary system, outlining the intra and extra bile ducts and gallbladder and cystic duct. Then the radioisotope is excreted to the duodenum. It's used in cases for functional assessment in cases of biliary atresia. As we see here in the early phase, they accumulate in the liver parenchyma. Then starting after 20 minutes to collect in the biliary system and gallbladder. Then after 45 minutes, it's excreted into the duodenum, which is normal, not seen in the cases of biliary atresia. Also, this technique used in acute and chronic cholecystitis also diagnosed. This is the high-def scan machine, and this is the gamma camera used in the after injection of the radioisotope. And thank you.